Good morning and welcome to Health Science Medicaid Nurse Aide. Mr. Justice here at the Millard Area Technical Center. We're going to talk a little bit today about Chapter 16 and about Chapter 17. Now, on your Infinite Canvas, I have placed your assignments beginning in the third 9 weeks. Your last 9 weeks ended last Thursday. They had extended it from Eastridge, Ms. Justice had. So we're going to talk about, going forward, we're going to talk about Chapter 16 and Chapter 17 in your MNA book. So let's talk about the resident unit. The resident unit is everything that consists of where the resident is going to live. That is their unit. Generally, when you walk into a hospital room or a nursing home room, you have a bed, you have a mattress. Depending on the nursing facility, you may have side rails to that bed. You may or may not. We've gotten away from those because of the increased risk of injury and even death for those residents who have side rails. In a hospital, you'll see side rails. In a long-term care facility, you may not see side rails at all. You'll have a nightstand, bedside table. There will be a closet and a couple of drawers for the resident. And that space is generally, if it's not a private room, that space is divided out into a semi-private, and there's 2 people living in that same room. Access to a restroom. Sometimes that's a central restroom between 2 patients or between 4 patients, 2 rooms back to back. And you'll have a curtain, you'll have a call light. Of course, light switches, plug-ins, those kind of things. Residents can bring their own things from home after having it cleared with the facility. Safety is always a issue. We want to make sure that the resident is safe and everything that they bring in is safe. As you look at Chapter 16 and you look at the resident unit, we talk about a number of things in this chapter. We talk about odors, noise. We want to control odors. We want to control noise. We want to make it as pleasant as possible for the resident. We want to have adequate lighting, and we want the color and the scheme of things to not kind of clash to the point that you might not be able to. Have you ever been in a room and you didn't know where to step because of the 3D optic that it gave off, and you're like, do I step here or step there? We want everything plain and simple to where we don't have any accidents. Generally, you will have, again, lighting, an overhead light, sometimes a light on the back or a light overhead. So when you look at the resident room, you need to become familiar with that room, become familiar with that bed and all the safety things that go along with that. How the operation of the bed, how does it operate? When I first started back in the day, it was all cranks. The left crank raised the head, the middle crank raised the bed up and down, the right crank raised the feet. If you had side rails, you had 2 different types of side rails. You have those that were actually attached to the bed, and you had little pull things on each side. Sometimes now you have a little lever or a hand button underneath that'll help raise and lower the side rails. You just need to become familiar with the equipment. Now, when a resident is admitted, you need to be able to explain to the resident and help them to be comfortable with their surroundings. Now, when we look at safety and promoting comfort, we look at the different positions that a resident can be in Chapter 16. On page 218 and 219, we talk about the red and all the safety areas the bed and all the safety areas surrounding that bed. On 219, you'll see some figures where residents can become trapped. And that's one thing we want to guard against. That's another reason why we've pretty much, in long-term care facilities, they've done away with side rails. But if you have side rails, you need to be aware of those zones. The overbed table, that's considered a clean surface. I mean, you don't want to put your urinal or your bedpan there. You don't want to put anything nasty there. You want to keep it clean. Generally, the resident will do activities on that overbed table. They'll use it just like a desk, or they'll take their meals there on the table or at a bedside chair. Generally, in a room, there's also a bedside chair for visitors or for the resident to sit in. All the equipment, the call system. With the call system, a central call system, they'll hit a button. It'll buzz generally over the door. It'll buzz at a central area at the desk. You never, and let me say this very clearly, you never cut the call out off at the desk or on the wall. You always go into the resident's room, you visit the resident, see what they need. If it takes, you may not be able to meet that need at that very moment, depending on what that need is. They may need some water or something. You may have to go back out of the room to get a refill of the pitcher or to go get something from the dietary department if they're hungry. But you always cut that light off there on the wall in the resident's room, so that way you see them. And we want to answer those call outs promptly, very promptly, to see what they need. That resident may be calling for help. That resident may be trapped or something medical may be going on and they need immediate help. And that might have been their last hope, is when they push that call button and waiting for you to respond for that. Now, I also know that we have residents who call out every 5 minutes. And we kind of get tired. It's kind of like the little boy who hollered wolf in the old story. But those residents need something. If they hit that button, they need something. If they have a cognitive deficit, they need your attention. They need to be reassured. They need to have if they have a need, sometimes they may not know the need that they have. And you have to play a little detective work. Are they hungry? Are they thirsty? Are they in pain? Are they having any anxiety about being left alone? What can we do to help them? I know that in some cases, over the years, I've brought patients, residents out to the nursing station in that area there and interacted with them and talked with them. And especially on night shift, everybody thinks you sleep on night shift. That's not necessarily the case. Just like we have different people work different shifts, people work different shifts all their life. And nighttime may be a time when they're used to being up, and then we put them in bed, or we help them and assist them to bed, and we encourage them to go to bed, because that's what everybody does, but that might not be normal for them. So keep those things in mind, and help align with their care plan what that person needs individually. Anytime closet, drawer space, be aware of that. The bathroom, handrails, side rails, there's generally a call light in the bathroom for them to use. Generally, that light will be a little faster pace. It's considered an emergency light when they pull it when they're in the restroom. It'll be a faster pace. The light may flash over the bed. Again, generally, emergency light you can't cut off at the desk or on the wall near the nursing station. You have to actually go in, which I think is an awesome thing. I don't think we need to be cutting lights off until we see the patient and make sure they're safe and help them to meet their needs. General rules on page 223. I want you to become familiar with it. OBRA and the Centers for Medicare and Medicaid Services requirements for resident rooms. They've got to be a certain size. They have to have certain equipment in there, and they have to be conducive to comfort. When we're in a resident room and also in the hallway adjacent to a resident room, we want to be cognitive of odors. We want to be cognitive of noise. People generally. Sometimes noise bothers them, and we've got to keep a certain sound level in the facility. We don't want at 3 o'clock in the morning yell down the hall, "Hey, Mary, to our fellow nursing assistant or nurse, I need this. Can you come and do this?" That's not the time and place to be yelling down the hall. Actually, you shouldn't be yelling down the hall at all unless you have a major emergency. And again, let me go back to our safety. You don't just run around if you have a fire saying, "Fire, fire," as that can cause panic and chaos. There's an orderly fashion to do things, and we want to do that. So that's the resident room. So let's look at chapter 17, beginning on page 226, and we're going to talk about bed making just for a moment. Again, this is not going to be a long video. These are self-explanatory videos that you can watch. But when we make a bed, it promotes comfort, it promotes cleanliness, it promotes and the fact that if we get all the wrinkles out of the bed and all the crumbs and all the things out of there, we actually increase circulation because we don't want to have pressure ulcers. Wrinkled sheets and extremely wrinkled sheets can cause indentions in the skin, can be uncomfortable. We change it because it's wet or soiled. Anytime that it's wet or soiled, we're going to change it. If we're talking about regular changes, generally twice a week on your bath day, whether that's a bath, shower, tub bath, whatever's in the care plan or whatever that resident desires. And when we gather our supplies and we take them in the room, once we gather those supplies, we don't use them for anyone else. If we don't use all our supplies, they go in the dirty linen. Anything that is soiled goes in the dirty linen. Now, for our infection control practices, we're going to be wearing gloves when we're going to come in contact And of course, with COVID-19, not only gloves, we're talking some gowns, we're talking masks, we're talking eye protection. We want to protect ourselves, and also in doing so, we protect the residents, not only the ones that we're caring for at that very moment, but for the others that we're going to come in contact with after we provide care for the resident that we are assisting at that time. And then we're going to do proper hand hygiene before and after the care that we provide. So you've got different types of beds. I'm not going to bore you and just reading to you out of the book today, but I want you to look at the different kinds of beds. You have an open bed, a closed bed. You got a surgical bed. Look at those practices. You have your skills manual. I want you to go over your skills manual. I want you to work through those skills and become familiar with those steps in the skills manual. That is can be part of the state test, is to make an occupied bed or an unoccupied bed. So we need to be prepared to do that. And hopefully when we get back into in-person class, we will be able to practice that on the beds that we have. Now remember, we have a 15% capacity right now in our state, in our school system. So if you want to come, there's some who have made appointments to come. I realize things cause you to cancel those appointments, things that come up. The weather we're having currently, the secondary roads may not still even be passable with the ice and the snow. But I encourage you to call, make an appointment, come up. 15% capacity, so I can have 2 or 3 students in this room at one time. And we have a large enough room, as you know, that we can spread you out to where there's greater than 6 foot distance between you, which is awesome. I set up 3 stations, and we would be in good shape. I just set up a station. I'm going to try to lift it up and show you right over there. See the lady sitting in the chair, and also the bed that's ready. That's one station that's set up for you when you come. What we're going to do there, we're going to practice bed making. We're going to practice transferring the resident from wheelchair to bed to wheelchair. Be looking at that in your information. But she's waiting on you to do that when the time comes. All right. So look at those questions. Finish the review chapter. Our next is hygiene, chapter 18, and I'll be putting a video up shortly reference to that. I will put this on my YouTube channel. Make me famous. Well, hopefully not too famous. That can go either way. That can go good or bad. Everybody has an opinion, and but this is the best I can do, so this is what we're going to do. But we would like to get back to in-person classes. FYI on me, thankfully, of course, we had COVID back last summer. Going into the fall there, July, going into August. And I've got my vaccine. I took my second dose of the vaccine day before yesterday. What kind of symptoms did I have with the second dose? Sore arm. I had fatigue. Felt kind of yucky for about 8 hours after I took the injection. For the rest of the afternoon, took a nap, which I usually don't do in the middle of the day, but I took a nap. Middle of the day, actually evening time. Got up the next day, which was yesterday, and felt great. My wife took the injection today. She's having some symptoms, chills, feeling hot, feeling cold, feeling bad. I was talking to our secretary, her daughter, who's also a nurse. She had the same symptoms, generally lasting 24 to 48 hours. 24 hours generally, they're over. Sore arm especially, but of having one of those symptoms. But I want to encourage you, when you have the opportunity to take the injection. Reading the news, I know that there are variants out there. The South African variant is the one that they're worried about more. Moderna is looking. I have the Moderna vaccination, and my wife as well. Those are taking the Pfizer. According to our medical director, Dr. Fannin, they're basically set up on the same principle of how they operate with the mRNA. And the CDC, one article that I read, that in places where the Pfizer's available and you've taken the Moderna and the Pfizer's available, but the Moderna is now not, they have said that you can have the Pfizer vaccine. Johnson & Johnson is coming out with a one-shot vaccine that's showing, I think, 60% effectiveness, 65%. But the South African variant, the Moderna, they're working on a booster shot to help cover that. but it's very promising that it will provide, the current vaccine will provide protection for us while we may be reinfected, according to Dr. Fossey today that I read. We may get reinfected, but we're not going to have the symptoms of hospitalizations and the deaths that we were having originally. So vaccination is the way to go. I know that we're worried sometimes about how quickly this vaccine came about, but after doing some research and what was put into this vaccine, I took the vaccine and I feel confident in the results. Now, does that mean I may get it and die? There's every possibility. We don't know. I could also be hit by space junk falling out of the sky. The wall could cave in. You just don't know. Life is uncertain. There's only one thing certain. Well, actually, I heard the old timers used to say 3 things are certain. You're going to live, you're going to die, and you have to pay taxes. Me, 2 things. You don't live and then you're going to die. One of the 2. Whether you pay taxes, sometimes that's really optional. It might not go good for you if you don't. And I guess I'm thinking of taxes because I just filled mine out yesterday. Well, guys, that's enough of my rambling. You can tell that I don't get to talk to a lot of people because of this vaccine, because I'm just rambling and rambling and talking and talking. But I look forward to having you all back in class. Will we be back Monday? My honest opinion, probably not until we get more people vaccinated. There's a lot of social, political, medical things that are involved in all of this. If we are, that's great. That works wonderful for me. I'd rather have you in class here. Will I have a mask on? Yes. Will you have a mask on? Yes. Will we be socially distanced? Yes. Will we take precautions? Yes. Will we clean desks? Yes. Yes to all those things that we did prior to when we were. But the infection rate is up. I heard the hospitals are starting to fill up a little bit more and more people. We're seeing those cases go up. Honestly, it may be March or April. I think once everybody gets vaccinated, we're very blessed to live in an area that we're for doing the vaccines. We did it for frontline workers, nurses. We're doing them for educational staff, for teachers. They're doing them for now people who are 70 and over. So, that's one thing we were worried about. You come into school, the children could be they may not get the severe infection, but they can transmit. And we were worried about what about parents and grandparents and those who are immunocompromised and suppressed related to their comorbidities of diabetes, cancer, autoimmune disorders, those kind of things. So, we get that population. I think that'll be part of the fix. So that's just me rambling. That and $1.50 will buy you a pop or a cup of coffee somewhere. But those are just my thoughts. Well, guys, I hope you have a great day. I'm going to put up some more assignments. I think today is Wednesday, the 3rd day of February. You've got some assignments, and I've got some due dates, so make sure you look at the due dates. Just FYI, I only have 2 criminal records checks for my M&A class. I want to encourage you to get those M&A checks. Are we going to get to go to the nursing home? I've not heard anything. They're not opening that up right now. So I'm not for sure how that's still going to work. But we'll do the best we can and try to make it through this semester. Guys, have a great day. Wash your hands. Wear your mask. Stay safe. Until next time. See you.